Hi, Miss Nikki here. Welcome to Chapter 20, Part 2. In this video, we're going to talk about blood pressure, and we're going to talk about some of the factors that affect blood pressure. So what is the definition of blood pressure? It's the force of blood against the vessel wall. So as the blood is moving through the vessel, it's putting pressure on the inside. So here's my artery, and blood is flowing through this lumen. And as the blood is flowing through, it's putting pressure on the inside wall of the artery. Pressure is highest in the arteries and lower in the veins. Remember, the veins are a little bit irregularly shaped. They have larger lumens. So you're going to have lower pressure in the veins and higher pressure in the arteries. So blood flow in the arteries is going to pulse with the cardiac cycle. So as the heart contracts or beats and contracts the ventricles and pushes the blood up and out, that blood is also going to pass through the arteries. Systolic pressure occurs when the ventricles contract. It's when the highest pressure is generated in the arteries. They're the most stretched out. The blood pressure ratio systolic to diastolic, we'll see in the next slide, that's relaxation, is about 120/80. So we're looking at the heart contracting or the ventricles contracting. That's what we're really focused on, right? And then we're going to see the ventricles relax. So that would be our diastolic pressure. This is when the ventricles relax, the pressure is the lowest, the arteries are going to recoil. Remember, they have elastic tissue, so they're going to do the stretch and recoil as the blood is pulsating through the arteries from the cardiac cycle. Diastolic number 80, blood pressure around normal. And remember, everybody can be a little bit different, just like body temperature. They mention here pulse pressure. If you subtract the systolic from the diastolic, that'll give you a pulse pressure. This tells you kind of the elasticity and the recoil of the arteries. It tends to decline as we age. Here we can see a visual representation. They're showing you blood pressure being taken. They're showing you a stethoscope to listen for the sounds. They're showing you the blood pressure cuff and then the gauge that we use, which is called the sphygmomanometer. So you can see systolic pressure about 120, diastolic at about 80, and you can see that as the blood is flowing, the blood is pressing, right, on the inside of the vessel wall, and this maximum pressure or stretch occurs from systole, or when the ventricles contract. And then the ventricles relax, and that's going to be our diastolic pressure. I like this image. It's showing you the systolic pressure at 120, and it's showing you the diastolic pressure at about 80. And then it's showing you what is the pressure as it moves through the vessels. So pressure is highest at the aorta. We can see as it's traveling through the arteries. Remember, we start with elastic arteries, then muscular arteries, then we finally get to arterioles. And right about here, they're talking about the arterial end of the capillary and the venous end of the capillary. So remember, capillary pressure, we talked about hydrostatic pressure pressing down, I believe it was 30, 35. And then on the venule side, picking back up, I want to say it was 16. That was the last example that we talked about. So they're just showing you that this is kind of the pressure change that we're at the capillary bed. And then you can see the venous return. And then as we're getting to the vena cava, superior, inferior vena cava, we're close to zero, right? Maybe 1, 2, 3, 4, but pretty close to zero. So blood is basically trickling back into the right atrium. So this is when we have blood pressure at the lowest. Capillary blood pressure, we really don't want it to be too high. We don't want it to be too low. In the last video, we talked about how pressure makes a difference, right? That the only thing that causes nutrients to be pushed out from the blood vessel into the interstitial fluid on the arterial side is the correct pressure forces, right? The hydrostatic pressing down, osmotic pressure pressing back. So we want the arterial end to be about 40, and we want the venous end to be about 20. And this accounts for the filtration, which is the drop off, and the reabsorption. So filtration, remember net filtration rate that we talked about. Okay. So then in clinical view, we look at cerebral edema, and we just want to talk about why is interstitial fluid, excess interstitial fluid in the brain bad? What happens if your mean arterial pressure is above 120? What happens if it's 160? So this would be really high blood pressure, right? And or systole, because I'm just giving you the top number. This is going to increase the filtration in the brain capillaries. We're going to be pushing tons and tons of fluid on the arterial side into the tissue, or into the interstitial fluid and then into the tissue. So we have this excess accumulation of fluid. So I'm kind of asking this question to kind of bring back 201 topics. Think about your brain. Is it totally encased in bone? Do we remember our cranial bones? Right? We had parietal, frontal, sphenoid, ethmoid. Occipital is the one that we're focused on. Do you remember the base of the skull? We had the occipital bone, and it had this foramen magnum, right? It's kind of a terrible picture, but I know you remember. Foramen magnum. So this giant hole is the only place that we have any relief, any place that fluid can go, and this is where your brainstem is exiting. So this could be really dangerous. We don't have room for this excess fluid if our blood pressure is too high. So remember, venous pressure is very low. It's almost zero as it enters the superior inferior vena cava back to the right atrium. So the venous return of the blood is going to depend on these three factors. We've already looked at pressure gradient. We looked at the blood flow in the capillary, and we just talked about the fact that you have to have pressure that's not too high and pressure that's not too low. We talked about hydrostatic pressure, osmotic pressure, basically that net filtration pressure that we talked about in part 1. We're going to look at these two now. And basically, all of these are going to aid in venous return of blood to the heart. So we can see here skeletal muscle pump. So the muscle contracts, it squeezes the vein, and blood is pushed into and moved quickly during exercise. So as you're contracting these muscles, you're squeezing the vein and you're pushing the blood further along in the venous return, and then the valves are going to come and close. So blood is going to get pushed, the valves are going to close and prevent backflow, and we're moving blood up back towards the heart as these muscles are contracting and relaxing. So an additional factor that helps return blood to the heart is the respiratory pump. So every time you breathe in and out, you are moving blood from one area or one body cavity to the next. You can see here during inspiration, the blood that's in the abdominal veins here is going to be driven towards the thoracic cavity. The abdominal pressure increases and the thoracic pressure decreases. In expiration, the blood that's in the thoracic cavity veins is going to be driven towards the heart, and the blood in the lower limbs is going to be driven into the abdominal veins. So basically, every time you breathe in, you're pushing the blood further up. We've already talked about a clot or thrombosis. Go back and look at the terms like pulmonary embolism. Does it make sense to you? Look at varicose veins. Basically, we have non-functioning valves. You can have dilated, so stretched out and kind of contorted or twisted in turns of large veins. Usually it's the superficial veins of the lower limb. The great saphenous vein is one that causes a lot of varicose veins. It can be due to genetics. It can be due to standing for long periods of time. The more pressure you're putting on your lower limbs, the harder that blood, that venous blood return is trying to make it back to the heart. Aging, hormones during pregnancy. So lots of issues that can result in varicose veins. You can also have hemorrhoids. We'll talk more about these when we get into digestion and we talk about defecation. But basically, if your abdominal pressure is increased, that's pushing on the veins that are around the anal region or anal sphincter. And then some of those veins can bulge out, and that's what hemorrhoids are. Another clinical topic we could talk about is circulatory shock. I also mentioned that circulatory is not a system. So remember, we have 11 body systems. We have cardiovascular, and we have lymphatic, which we'll talk about next chapter. If you add those two together, they'll call that circulatory system. It's not really a body system. It's not one of the 11. It's the combination of two. So both of these have to do with all of the fluid that is kind of moving through the body. So it'll make a little bit more sense when we talk about lymphatic. But circulatory shock means insufficient blood flow. So we're back to that term about perfusion, making sure that the tissues get enough oxygen and glucose. This can be due to some sort of heart impairment. If your heart's not pumping effectively, you're not going to have blood under high enough pressure. It's not going to perfuse all of the tissues. You're not going to get oxygen. Those tissues are going to die. If you have any kind of swelling or fluid buildup, that is going to cause low venous return. So again, if you have low venous return, you're going to have low stroke volume. You're going to have low cardiac output. You're going to have low blood flow, right? We've talked about hemorrhaging, dehydration. You don't have enough water. So if you have decreased water, that's going to be decreased blood volume. That's going to have decreased blood flow, decreased blood pressure, right? And that's not enough to deliver nutrients to your tissues. You can have obstructions of veins. You can have venous pooling. So that kind of leads to what we talked about up here, that low venous return. Now we get to move into actually talking about blood pressure and how blood pressure can vary depending on these factors or changes in these factors. So systemic circulation, blood pressure, is the driving force to move blood through your vessels. Increasing blood pressure causes an increase in total blood flow called cardiac output. So hopefully we're thinking increase in cardiac output, increase in blood flow, increase blood pressure. So basically, as the blood is flowing through the vessel, it's putting pressure, and that's blood pressure. So we talked about cardiac output already when we talked about the heart. We talked about heart rate times stroke volume equals cardiac output. These were basically factors that could increase or decrease depending on the heart function. We're going to talk about peripheral resistance, which has more to do with the vessels. So the vessels can dilate, or the vessels can do constriction, and that can change your blood pressure as well. Blood volume, this is when we're going to talk about the hormones. And hopefully, I'm going to write it down here, hopefully we can think about if I increased water in my blood, and that would increase my blood volume. If my blood volume goes up, how is that going to affect my blood flow? How is that going to affect my blood pressure? So blood volume increases, blood pressure increases. So increased blood volume, increased blood pressure. So what kind of hormones can cause an increase in blood volume? We're going to come back and talk about those, right? But ADH, aldosterone, I forgot the D there, right? Are we probably going to talk a little bit about epinephrine and norepinephrine? Yeah. We're also going to talk about a hormone called renin. And we're going to talk about a hormone called atrial natriuretic peptides. So we're going to come back and talk about those. So cardiac output, total blood flow, varies with changes in heart rate and stroke volume. We should already know this. So heart changes, right? heart issues, heart changes. This heart rate can go up or down, stroke volume can go up or down. We already talked about the factors that increase or decrease heart rate and stroke volume, and then that can cause cardiac output to go up or down. Remember, cardiac output is equal to blood flow, which is equal to or influences blood pressure. Resistance is the friction. So I like to think of it as bumps in the road. If you're in a place that has a skating rink, or you've seen hockey teams on TV, you know they go out there and they smooth the ice out, right? So if the ice is really smooth, the skaters can go really fast. If there's bumps or divots, it's going to slow them down. It's the same thing with resistance. So peripheral resistance is resistance of the blood in the blood vessels. So if your blood is thicker, that thickness of blood causes greater viscosity, which raises resistance. So the thicker your blood is, you're going to have increased peripheral resistance. Vessel length. The longer the vessel is, the more friction it encounters. So long pathway, and you're going to see increased peripheral resistance. Lumen size. The smaller radius creates more resistance. So they're saying if you're looking at the lumen, so this part right here, the opening, the smaller it is, the more resistance we have. As opposed to, let's say, a vein where we have a larger lumen, right? So this area here is larger in the vein. Total blood flow is proportional to pressure. So blood pressure increases, blood flow speeds up. If blood flow speeds up, blood pressure increases. Blood flow is inversely proportional, does the opposite, to peripheral resistance. If resistance is high, blood flow decreases. So what happens to blood pressure? It decreases. We have ways to fix this. We have ways to compensate for this, right? If you have lots of plaque buildup in your arteries and your blood flow is too low, your perfusion rate is low, your tissue is not getting enough blood, your body's going to try to elevate this, right? So they make it a point of saying that the resistance being inversely proportional does not apply if you change the diameter of the blood vessel. So they're saying this, if the blood vessel diameter, the lumen opening, if the lumen opening stays the same, these apply. But we can vary, because we have muscle here, we can do vasoconstriction and vasodilation. So if I open the tube or close the tube, that is going to change the resistance and the blood pressure. So as resistance increases, total blood flow decreases. So increased resistance equals decreased blood flow, decreased blood pressure. If I decrease the resistance, that equals increased blood flow and increased blood pressure. This image here is showing you the vasodilation. So vasodilation, I'm going to make the lumen larger, right? So the opening, the lumen is larger. Here we have vasoconstriction, and the vessels are making the lumen smaller. So greater resistance caused by vasoconstriction, less resistance caused by vasodilation. So just kind of think for a second, if my blood pressure is too high, right? So I'm going to say triple, right? My blood pressure is too high. I can do vasodilation, and vasodilation will cause my blood flow, blood pressure to go down. Vasoconstriction, if I make the lumen smaller, vasoconstriction is going to cause increased blood pressure, increased blood flow. Sorry, it's supposed to be an F. Blood pressure must be kept in a proper range, high enough to maintain tissue perfusion, not so high as to damage the vessels. So think about the fact that if the blood is returning to the heart at the right atrium, we do not want the pressure to be super high because it can damage the heart itself. It could damage the great vessels that are delivering the blood to the heart. Think of that endothelial lining, right? So these variables are all going to be regulated by nervous system or endocrine. So we're going to talk about some receptors here that the nervous system, or the receptors, can determine there's a change and send that message to the nervous system for the nervous system to decide what to do. And then we also have the endocrine system, so we're going to come back and talk about those hormones again. So first we have to look at neural regulation. So we're here, neural regulation, short term. You're going to have autonomic reflexes. You're going to have a cardiac center and a vasomotor center. Cardiac center basically talks to the heart, and it increases, or it has two factors. It can increase heart rate. If you increase heart rate, you increase cardiac output, which increases blood flow, increases blood pressure. It can also decrease the heart rate, which would decrease cardiac output, which would decrease blood flow, which would decrease blood pressure. There's also the vasomotor center, which influences vessels. And this particularly has to do with the diameter, the smooth muscle, the vasoconstriction, vasodilation. So epinephrine and norepinephrine can bind to your blood vessels and tell those blood vessels to vasoconstrict or vasodilate, so they can cause an increase or decrease in blood pressure. Baroreceptors are another neural regulation, again short term. We have nerve endings that respond to stretch, and the two most important here, aortic arch and carotid, which is going up to the brain. So we're going to see in the next image, these baroreceptors are going to detect stretch in the blood leaving the heart, and they can send signals to that cardiovascular center that we just talked about. This image here, so in green are the baroreceptors. So baroreceptors detect stretch. So if the blood is coming up and out of the left ventricle and it's under super high pressure, the stretch, the pressure, blood pressure, is detected by the receptors, and they send a message to the brain stem right here in the medulla oblongata, and they're going to cause activation of the vasomotor center and the cardiac center. So we're going to see that this increased blood pressure, this stretch, can do two things. One, it can tell blood vessels to try to compensate. So the blood pressure is high. What could I tell the vessels to do? I could tell them to dilate, right? That'll cause, if I increase the space in the lumen, that decreases blood flow, decreases blood pressure. What else could I tell the heart to do? I could send a message to the SA node or the AV node, right? And I could tell them to decrease heart rate. If I decrease heart rate, that decreases cardiac output, that decreases blood flow, that decreases blood pressure. Have I accomplished my task? My blood pressure was high, and now my blood pressure is low. So you could also look at if your blood pressure was too low, what could we do? We could initiate the cardioacceleratory center, and we could speed up heart rate, and we could do vasoconstriction. So here we just have the words. it gets a little confusing because they're telling you which areas are being turned off and which areas are being turned on. So they're saying if the blood pressure increases, so if we have high blood pressure, the baroreceptors are going to detect the stretch, right? The baroreceptors are going to increase their firing rate. They're going to be sending more messages to the brain. This causes the accelatory center to send less signals and causes the inhibitory to activate parasympathetic pathways to the AV and the SA node. It causes the vasomotor center to send less signals along the sympathetic pathway, and that's going to allow for vasodilation. This will cause a decrease in cardiac output because it caused a decrease in blood flow. It'll cause a decrease in cardiac output, and this lowers the blood pressure. So baroreceptors are ineffective for long term, but they're really good for short term. Next, we have if the blood pressure decreases. So the vessel stretch declines, the baroreceptors slow down, they stop firing as fast. We're going to activate the cardioaccelatory center. We're going to stimulate the sympathetic pathways to increase cardiac output. So that's increasing blood flow, ultimately going to increase blood pressure, right? We're going to inhibit the inhibitory center to minimize the parasympathetic rest and digest. Remember, we're already too low. This activates the vasomotor center to stimulate the sympathetic pathway to cause vasoconstriction. So vasoconstriction will cause increased blood flow and increased blood pressure, which ultimately we want to do the opposite because we started with low blood pressure, and this will have or cause an increase in blood pressure. Next, they're talking about chemoreceptor reflexes. I just want to kind of put this out here for when we come back and talk about respiratory and urinary. So this is just another way that we can regulate blood pressure, and we're still talking about neural regulation. So these chemoreceptors can influence blood pressure depending on the blood chemistry. So in this case, they're saying high high carbon dioxide and low oxygen. So why would this cause your blood pressure to increase? Does it make sense if our carbon dioxide level is too high that we want to increase our blood flow so that we can exhale and get rid of that CO2, right? We want to increase blood pressure, increase blood flow so we can get more carbon dioxide out and more oxygen in. They also want to make sure that we realize it's more than just the brainstem that can be involved in regulating blood pressure. So you can see here the hypothalamus can increase cardiac output. The limbic system can also alter blood pressure in response to emotion, memories, anxiety, things like that. So multiple ways to regulate blood pressure. So now we're going to move on to talk more about hormones. So in this image, and then we'll move on into words and then other hormones, we're seeing that the kidneys, in response to decreased blood pressure, are going to release something called renin. And renin is going to convert angiotensinogen into angiotensin 1. Then angiotensin 1 is converted into angiotensin 2 by another enzyme, this ACE, angiotensin converting enzyme, and this is released from the lungs. Angiotensin 2 is the active form, and angiotensin 2 can increase blood pressure by these various means. So it can cause vasoconstriction. So if you have increased blood flow, that'll cause increased blood pressure. It can stimulate thirst, so uptake water, right? Drink water. And decrease urine formation, that's also reabsorb water. If we reabsorb water, that increases our blood volume, that increases our blood flow, increases the pressure being put by that blood on the inside lining of the blood vessel, right? So blood pressure. So was our blood pressure low, and did we activate angiotensin II to raise our blood pressure? Yes. So just in words, the liver makes the angiotensinogen, the kidneys release renin in response to low blood pressure. Renin converts angiotensinogen into angiotensin 1, and then this ACE enzyme converts 1 into 2. So hopefully we can see there's lots of players here, right? The liver, the lungs, the kidneys, these are all releasing factors that ultimately activate angiotensin II. Angiotensin II raises blood pressure. We just talked about the fact that it's a vasoconstrictor. It stimulates thirst, so that increases our blood volume. It acts on the kidneys to decrease. So that's also going to increase blood volume. And then angiotensin II also activates aldosterone and antidiuretic hormone. We know what aldosterone does, right? Aldosterone is going to increase the absorption of sodium ions. That's going to increase the absorption of water because these two are co-transported together. That increases our blood volume, that increases our blood flow, increases our blood pressure. Antidiuretic hormone increases water reabsorption, stimulates thirst. All of these are to increase just water. So there's no sodium here. We're talking specifically targets the kidney tubules to reabsorb water. Reabsorb water, increase blood volume, increase blood flow, increase blood pressure. ADH is sometimes called vasopressin because it also can trigger vasoconstriction. Here we have the one hormone that is actually released if you have high blood volume, high blood pressure. So if you have high blood volume, high blood flow, high blood pressure, and the atria of the heart, when those walls are stretched, atrial natriuretic peptide is going to be released. So if you have these conditions, it's going to release atrial natriuretic peptide. It's going to stimulate vasodilation and increased urine output. So vasodilation, right, that's going to decrease blood flow, decrease blood pressure. What about increased urine output? So more water out, blood volume goes down, blood flow goes down, blood pressure goes down. So atrial natriuretic peptide, your blood pressure is too high, detected by the atria of the heart, and we're going to start the process of decreasing our blood pressure. In lab, we'll look at measuring blood pressure. A sphygmomanometer. A sphygmomanometer is the dial that's used on a manual blood pressure cuff. I know in lab we have both digital and manual. Basically, you're going to take the cuff, you're going to wrap it around the arm, you're going to put the stethoscope on the brachial artery. You're going to inflate, pump up the cuff until the artery is compressed. The pressure in the cuff is decreased. You're going to release the little air valve slowly, and you're going to look for the systolic, which is when the pressure in the arteries, when the heart contracts. You can hear this in the stethoscope. It's kind of a pop noise. And then the diastolic pressures, the bottom numbers, the pressure in the arteries when the heart relaxes completely. There's no longer a sound because the blood is flowing out smoothly. Hypertension, 140/90, maybe due to blood vessel wall damage, could be due to thickening of the arterial walls. It is the major cause of heart failure. Hypotension, anything below 90/60. And then orthostatic hypertension. This is interesting. When you go from laying down to suddenly standing, you have this decrease in blood pressure. It's almost like you can't adjust your blood vessels enough, or you're not sensing that that needs to be adjusted, like your baroreceptors, right? So basically, as you age, this is something that's pretty common. You aren't able to accommodate for that sudden standing. Remember, if your blood pressure drops too low, you're not getting enough blood flow perfusion to your brain, right? And so the easiest way to combat that is you're going to faint, and then when you're down, when you're laying down, your brain can get enough blood flow, right? So dizziness, lightheadedness, fainting, blood pressure regulation is not occurring quickly enough. The next slide, I don't want you to memorize any of the numbers. I just want you to look at, are there times that we need to move blood to certain areas to meet the needs of that tissue? And hopefully we're all saying yes, right? So total blood flow during exercise is going to go to the areas where it needs to be the most, right? We're probably thinking of skeletal muscles, right? So the heart's going to beat faster. We're going to push blood from the venous reserve back into circulation. Blood is redistributed so that it goes to the active tissues. I think it's kind of important just to look. We're talking about 10 times as much blood is being pumped to the skeletal muscles when you're working out as opposed to at rest. You can see the heart, that's about 3 times as much blood, right, to the heart muscle itself so that it can beat faster. And then you can see that there's a drop in blood to the kidneys and the abdominal organs. For lab, you are going to have to trace a drop of blood from the right atrium through the heart, out to the lungs, back to the heart, and then through the systemic circulation, either to the right bicep brachii, left bicep brachii, the right gastrocnemius muscle, or the left. So you're going to have to go to both arms and legs. And then you're going to have to follow the return back to the right atrium. So in this image here, we've removed the heart so that you can see the thoracic aorta. You can also call it the descending aorta. Usually people call this part the ascending, this part the aortic arch, this turn as the descending aorta, and then once we're here, we're in thoracic aorta. But again, I'll take either description, it's fine. And then you can see it passes through the diaphragm, and now we're in abdominal aorta, and we're going to iliac artery. On the venous return, you're coming up the iliac vein, you're going to the inferior vena cava back to the right atrium. For the arms, you're coming from brachial vein, and you're going brachial vein to, right subclavian vein, and right subclavian vein is going to merge with jugular, so this is jugular vein, this is subclavian vein, and those two are going to merge into the right brachiocephalic vein. On this side, you can see the left subclavian vein, you can see the left jugular vein, and they're going to merge at the left brachiocephalic vein, and then both of those are going to dump into the superior vena cava. So something to note, we have 2 brachiocephalic veins, but there's only 1 brachiocephalic artery. Here in the abdominal cavity, you can see gastric, splenic, hepatic. They're kind of giving you the root words there and explaining to you that these would be the arteries feeding those particular organs. There is some overlap. So we're going to have this bundle, which is called the celiac trunk, and it's going to come out to the hepatic artery to feed the liver. It's going to come out to the stomach. That would be the gastric artery. And then part of it is going to go over here to the spleen, and that would be the splenic artery. So for this test, all of these abdominal organ arteries and veins are going to be extra credit. When we get to digestion, you will have to know them all and be able to label them all. The one that's probably not very intuitive is this mesenteric. So mesenteric for us right now is going to be large and small intestine artery. So you can see the superior feeds part of the large here, part of the large here, and then this is small intestine and this is small intestine. So you're going to have a branch that comes off on top, that's the superior mesenteric, and then you're going to have a branch that comes off towards the bottom, that's the inferior mesenteric, and you can see that they come around and feed all of the large intestine in this picture, but then remember small intestine would be on top. And so we have all of these little branches. So for us right now, we can kind of just group them together. If you see the word superior inferior mesenteric, it's feeding both large and small intestines. We will come back and talk about hepatic portal system, but I want you just to see a picture of it right now, that we have all of our intestines, our stomach and our spleen are all draining their blood into this hepatic portal, which then takes the blood to the liver and it's cleaned before it gets dumped back into the inferior vena cava. So anything that might have bacteria on it, fungus on it, things that you've consumed, right? So all the spleen, the stomach, and the intestines are all going to filter their blood through this tube, which is called the hepatic portal system, to the liver. It's going to clean the blood, and then we're going to put it back into the inferior vena cava, because then it goes to the heart. So we're just cleaning the blood before we pump it back into circulation. For the right limb here, I just want to go over that we'd have our brachiocephalic artery. Here's our aortic arch. We'd have our right brachiocephalic artery. And that right brachiocephalic artery is going to have two branches. This is going to be the right carotid. And this, you can see, is leading to the right subclavian. So subclavian artery, then it turns into axillary, then it turns into brachial, and then you can see it splits, and we have ulnar artery on the pinky side, and we have radial artery on the thumb side. But you can see there's more veins draining back. And this is an example of that venous anastomosis that we talked about earlier. So you can see all the veins draining from the forearm. We have a radial vein, we have an ulnar vein, and we have several others, right? And then they're going to merge. And again, we have brachial, basilic, cephalic. And then we get to axillary, then we get to subclavian, and then we dump into brachiocephalic. So a lot more venous drainage. But for us, we're just going to have to know the basic ones, right? So you need to know brachiocephalic vein, subclavian vein, axillary vein. You need to know brachial vein. I think mid-cubital is on our lab sheet as well, and then radial and ulnar. For the lower limb arteries, you can see the iliac artery. We're not going to talk about external, internal iliac. We're just going to say iliac artery. That's fine. And then we're going to move into femoral artery. And then this is a posterior view. If you can't tell, this is the back of the knee, right? So this is the posterior. So we have to know iliac to femoral to popliteal to posterior tibial, because we have to go to our calf muscle, right? Our gastrocnemius. For the drainage back, if we're here at the calf muscle, right, we've dropped off oxygen, we've picked up CO2, we're coming back the gastrocnemius capillary to gastrocnemius venule to the posterior tibial vein to the popliteal vein to the femoral vein, and then back to iliac. And then the iliac vein is going to drain to the inferior vena cava. Lastly, these few slides, we're just going to look at comparing fetal to postnatal circulation. So we did already talk about the foramen ovale, the opening between the right and the left atrium, but obviously there's going to be differences in fetal to newborn. So fetal lungs are non-functional, right? So, and we get, as a fetus, we're getting oxygen and nutrients through the placenta from mom. So there's going to be a lot of vessels that are going to shunt blood to the organs that they need to and shunt blood away from immature organs. So the oxygenated blood from the placenta is going to enter the fetus, umbilical vein. we're going to see that the blood coming from the placenta directed towards the inferior vena cava through something called the ductus venosus. We're going to see oxygenated blood mix with deoxygenated blood. We're going to see blood passed from right to left atrium in the foramen ovale. We're also going to see blood as it enters the right ventricle pumped to the pulmonary trunk, that some of it is going to be shunted to the aorta. And that's through the ductus arteriosus. So normally, remember, we got our pulmonary trunk that's going out to the lungs, and then we have our aorta, which is going to our systemic system, or body system, right? So what they're saying is there's kind of this crossover point. There's this ductus arteriosus that is allowing a mixing of blood between the pulmonary trunk and the aorta. So after birth, these shunts should close. So the umbilical arteries and veins become non-functional, right? The child has been born, there's no longer a placenta. The ductus venosus ceases to function and constricts, and then we call it a ligamentum. Then the foramen ovale closes, it's a fossa ovalis. Ductus arteriosus closes, and again we have this fibrous ligamentum structure. So let's look at the image. You can see here the ductus arteriosus. This is where the pulmonary trunk is mixing with the aorta. You can see the ductus venosus. This is where we have the umbilical vein here that's mixing with the inferior vena cava. And then we have here the foramen ovale, which is the mixing of blood between the right and the left atrium. So again, there's no questions on this Unit 2 exam about fetal circulation. Again, we're just kind of going over it right now because we're talking about the heart and blood vessels. And when we come back to reproduction chapter and development chapter, we'll come back and talk about fetal circulation. All right, guys, I'll talk to you soon. Bye.